was really unhappy at school. I was very miserable. I had a lot of problems at home. And I didn't have anybody to talk to. And I was withdrawn, and I suppose I kept all my feelings in, and that's how I dealt with my feelings, through self-harm.
Self-harm is a very personal thing. I can only speak for myself. When I self-harmed, starting at 17, I was self-harming to punish myself. I hated myself. I saw myself as a dirty, bad person.
I didn't tell anybody because I thought it would be seen as something really strange and people wouldn't understand. I didn't really understand myself.
When I did it, I found that it relieved the terrible turmoil that was going on in my head, and for a short while I got peace. It stopped me topping myself, basically.
I was very ashamed. I didn't want anybody to see them scars at all. And I always thought if people saw them, they would think that I'd tried to commit suicide, and I hadn't. I tried to slash my wrist and I hadn't. I suppose in them early days, it was a cry for help, but I didn't want to tell anybody. Inside, I was crying out for help, but I couldn't get it on the outside.
My true friends know a bit about my past, and they accept me for what I am, so I don't have to put on an act with them. They accept me warts and all. But if somebody is labelled as a self-harmer, they get treated differently. They are a problem. Society sees them as weird, as maybe dangerous to other people, when in fact most self-harmers are harming themselves only, and they take their emotional pain inwards.
It's something I've lived with for a long time but haven't discussed. And there's been times when I've gone years and not felt the need to. And then all of a sudden, out of the blue, something will happen, and it's like an old friend that you fall back on again to get you through things.
The myths make it difficult for people to receive the understanding and the help that is necessary. A lot of what is done for them, people who self-harm, is counterproductive and damaging. At 17, I was labelled as having a personality disorder. In fact, I'd gone through a very, very traumatic experience and was reeling from it. But giving me a label and putting me in a psychiatric hospital and doping me with drugs just institutionalised me and kept me in the system for longer.
I think when we talk about self-injury, what we mean is the sort of direct injury to the body, like cutting various parts of the body or burning. But this sort of self-injury, I think, needs to be set within a more general context of self-harm, because we all self-harm in some way or another. For instance, smoking, drinking too much, driving too fast. Self-injury is very direct. It's seen as a direct injury, whereas the harm that comes from other behaviours is often seen as by the way and longer term, even though they might be more dangerous. We know that smoking's harmful, but we say things like, well, it helps me cope with stress, and the harm is a sort of byproduct. But then self-injury can be seen in the same way. It helps to relieve stress. It helps to cope with unbearable feelings. The fact that it might be harmful could be seen as by the way.
I think it's a subject which has been kept really quite secret in some ways. People are ashamed of it. They don't like it to be known that this is what they do. Overall, I'd say you could talk about maybe 1 in 200 in the population. That's about 0.5% who actually harm themselves to the extent that they need help. The actual level of self-harm is about equal between men and women.
Self-injury needs to be understood as being a way of coping. and a way of expressing distress. And in that way, it's interesting really, although of course it's a destructive and negative thing to hurt your own body, it's actually also a sign that a person's alive and kicking, that they're trying to cope.
What happens is people see the injury but don't look beyond it. What I would say is that people should look beyond it. They should see the whole person. They should see the distress and the internal pain that's going on. The things that can't be seen, that maybe self-injury helps make visible. You know, if a person is injuring themselves, there's a reason for it.
I carried out some research with quite a large number of women who self-harm or self-injure. In the end, 76 took part in the research. Reasons a person might injure herself was because of a build-up, usually, of unbearable feelings. So a feeling kind of overwhelmed with emotional pain or sadness or grief, desperation, which just felt like there was nowhere else for it to go.
Quite a lot of the women who come to us hurt themselves one way or another. We don't always know right at the beginning, but quite often it comes out if people are talking with us for any length of time.
Most of the people that took part in the research felt that things had happened in their childhood or teenage years which gave rise to some of the distress which then led to the self-injury. But there was also things that happened in their more recent lives. And the sorts of things were various sorts of abuse and neglect, sometimes loss, like losing a parent, a child losing a parent, or parents being very ill, not really able to cope. There's also things, I suppose, for smaller numbers, like bullying or racism or difficulties around sexuality.
Because of the work we do, most of the people who come to us who self-injure have been through some form of childhood abuse, sexual abuse. But that's not the only reason that people self-injure, obviously, and it's not the only thing, not the only way people react to childhood abuse, but it's certainly very common. There's quite a strong link between the two.
I think access to services and being believed when things are going wrong when you're younger would make an enormous difference to a person's ability to cope later in life. I was sexually abused from when I was 6 until when I went into care at 12. If I'd been offered counselling, if somebody had sat me down and gone through, helped me to come to terms with what had happened, if they'd gone through right from when I was 6 and allowed me to talk about things and lay the ghost to rest and say to me then, you know, that wasn't your fault, you know, you're a child, I exonerate you, then I'm sure I wouldn't need to cut my arms and set myself on fire, and, you know, I would have forgiven myself.
People talked about feeling very lonely, empty and needy and kind of desperately in need of some sort of comfort. And it's a paradox, really, that self-injury can, for some people, can be something that's comforting. It's something that's familiar and known, that they have control of. That they can bandage up, almost as though in healing the outside wound, it sort of heals some of the inside wounds as well.
There are a lot of myths around about self-injury. Some people see it as a failed suicide attempt, when in fact it's quite the opposite. The intention usually is not to die, but to live, to survive. It's a coping strategy that helps people stay alive.
I think it's very much a mistake to see self-injury a lot of the time as being designed to affect someone else or to draw attention from someone else.
Often the behaviour is done in private and the person doesn't even discuss it with other people. So in those cases it couldn't be seen as attention-seeking. But where it is communicated to others, and where maybe the intention is to communicate it to others, to communicate the distress that's beneath it, to dismiss it as attention-seeking is saying that this person is not worthy of attention.
If you actually gave somebody who said that to you a blade and said, right, take this to your own skin and cut through it, I think that they get the message that it's not something you do easily.
We use that term quite often, attention seeking, to dismiss someone, whereas being in need of attention, one's feelings being in need of attention, is a pretty important thing and should be taken seriously.
I mean, I went to the doctors and I was desperate. I was going through a bad stage and said I was cutting a lot, more and more of my body all the time, pushing it one step further, and I was scared of myself because I couldn't control it. She was very sympathetic, but she had no information to offer me. And if my doctor had given me a leaflet and information and a book about how to cope with it and first steps to stopping and things like that, then I'd have felt, well, at least somebody could have helped me out there. Somebody understands.
When somebody who isn't trained in self-harm or has no understanding of self-harm sees somebody like me, all they see is the scars, and you know, they can't understand it. But what is actually underlying the self-harm is a lot of emotional distress, which maybe they haven't got the time in an A&E department to focus on, and they can't see, because all they see is what is presented to them, which is the cut or the burn.
People's subjective experience of having very critical or abusive experiences in other healthcare settings is something that we hear about quite a lot. With the difficulty a lot of people have in communicating how they feel, very often there's a part of them which creates the mismatch, backed up, I guess, by the fact that so few people really understand very much about self-harm. It's not surprising in some ways that a lot of people's experiences will be ones which feel quite critical or harsh.
On one occasion, I was taken from a psychiatric hospital with a nurse escort, taken to casualty, and I needed stitching. And the casualty officer got me by the throat, pulled me into a room, and left the escort outside. Pinned me against a wall and wanted to know why am I doing this to him? Like I was somehow attacking him, I was doing it to get at him. On another occasion I was pinned down by 4 people and given 30 stitches without anaesthetic, which not only was painful, but the whole experience was dreadful, to be held down like a criminal and treated in that way.
It's very difficult not to pick up on what the people around me have been saying, and that tends to be, we haven't got time, apart from anything else, and if the person is a regular in the department, then it is definitely a case of, oh, just stick them in a corner till the psych team come and we'll get on with the more important things.
There is a lot of stress here. If I've had a long day here as a junior doctor, stitching people up, cardiac arrest, otherwise, talk to grieved relatives. I see someone coming for a 5th or 10th time having cut their wrist, I may lose my patience and sympathy.
We need people who are aware of what goes on out there in the big wide world. This is not an unusual thing. It's not as usual as falling over and breaking your leg, slipping down and doing your hip in, being knocked over by a car, but it's out there and it goes on. So there is a need for more awareness. There is a need, I think, perhaps also for self-awareness. It's very easy to be judgmental. We all do it. We're all victims of our own prejudices.
What sticks in my head actually is an overdose. That's probably the first form of self-harm I've come across, was a lady who overdosed. She's quite irregular, and she does tend to come, obviously she's coming back and forward quite often. She was just another familiar face, and she's back in again. You know, we're busy, and you know, in all honesty, when you have someone who comes in and it's another washout, it's an overdose, you do get a bit blasé about it, and you do think, you know, oh gosh, you know, not again, when you could be dealing with someone who's chest pain, etc. I mean, that does cross your mind when it's busy. But the time when I actually spoke to her and I understood the reasons as to why she was doing it, you know, then it just changes everything.
There's one nurse in particular who used to smile You know, while I'd been stitched up, she wouldn't say anything, but she smiled, and that made an enormous amount of difference. You know, she wasn't an ally, but she was human. She recognised that I was in distress.
Perhaps someone who self-injures just needs a bit of silence, an arm on the shoulder, a hand hold, at a time when the practical work is being done.
This is one of the busiest departments in the southeast of England. We have, on average, 90,000 patients a year. Between 1 to 1.5% of the patients' population can be classified as deliberate self-harm. In a busy any department, and most are busy these days, it is not difficult to miss the significance of some of these presentations. I like to think that over the past decade or so, there's been far more awareness, both in medical training and nursing training, about special attention to this problem. But if you don't have clear guidelines in place, if you don't have regular teaching and training in place, if you don't have audits in place, then bad practice will take place.
I think that some of the most negative responses sometimes come from accident and emergency departments, where if they're not understood, the response is, oh, this is a nuisance. The traditional psychiatric services are not necessarily as punitive as that, but they do see this as a kind of extension of suicidal behaviour, and people are, I think, sometimes unnecessarily put on Section 3 and given a lot of protection when in fact that's not the best thing for them.
I think that psychiatric services have had some rather kind of confused and conflicting approaches to self-injury. I think it used to be, self-injury used to be seen as either to do with being psychotic and mad, in which case the person couldn't help it, or to do with being bad and attention-seeking and manipulative, in which case the person was naughty and should stop it.
Most psychiatrists just want people to stop self-harmers to stop self-harming, but it's not as simple as that, and it's pretty unrealistic. It's a way of coping, and it's been a way of coping maybe for many years, and you can't just stop your way of coping.
I think in more recent years, some of the psychiatric literature reflects actually an understanding that there's a bit more to it than that, and that self-injury has certain sort of functions for people, but that understanding hasn't really permeated very widely in the services. It's not uncommon for people to have the experience of going somewhere for counselling or to a psychologist or to a group or somewhere, and for them to say, well, come back when you've stopped hurting yourself. You know, we don't actually work with people who hurt themselves, and you've got to stop that first. And it seems to me that's rather like saying come back when you haven't got any problems anymore. I think there are a lot of things that services, existing services, can offer people who self-injure. Things that staff are already able to do, which is to listen to people and to talk with people about their feelings and their experiences, and to help them to understand their self-injury in terms of their feelings and experiences, and to express things about what's happened to them.
On this unit, we've really worked around by a kind of trial and error approach to the policies which we now use. In the early days, we started with using quite a lot of Section 3 and giving people heavy medication and the DDCT. We found in the end that this was not a very productive way of working, and so we developed the approach of giving our residents more responsibility for themselves. So, for instance, we did not necessarily remove razor blades from them. We don't prevent them from having the means of self-harm.
Self-harm here doesn't need to be a secret, which is often quite a big thing, really. People keep it very hidden, very private, I guess. Here it's on the agenda, people are able to speak about it, and I think there's quite a sense of relief by being able to be more open about it.
We do give people a fair degree of power and control over themselves, and there is a feeling with a lot of our residents that in the ordinary course of life, and especially during their childhood, they didn't have much power and control. They weren't listened to, they weren't given choices. The other important input is usually on the basis of trying to alter their attitudes towards trauma that has happened in the past, and which in many cases, even though they were children, they may feel responsible for. We have projective art and drama and writing therapy, which can all be quite good in a way of getting people to express the things that they find it difficult to express.
I suppose another major bit of the work is getting people to know more about their self-harm, which is probably geared more towards harm minimisation rather than people being abstinent from self-harm. I suppose quite a bit of the work is geared towards getting people to tolerate the sort of greyness of life, of things being just good enough, really.
Each unit's different because you're not treated like a second-class citizen, you're treated as an equal, you're treated like a human being.
I think that sometimes staff can feel helpless in working with somebody who self-injures. I think that they can be frightened at the extent of the self-injury and worried about the responsibilities and the risk involved. And I think sometimes there's a tendency for people to try and take the responsibility away from that person and take control of the situation, which is exactly what we're trying to get away from.
Things that workers need, for example, are to know that they're going to have the backup of management, to have some guidelines in their service for how to approach self-injury, to know that they're not going to be left to carry the can if somebody they're working with hurts themselves. Because if they don't have that sort of backup, then they're bound to want to cover their backs and to just control people. People need not to be expected to work with huge caseloads of people that are in that kind of distress. They need a bit of a balance so that they're not being pushed beyond their limits, really. Because it can be almost like a kind of trauma for people to work with people who are hurting themselves. And they also need training and contact with other workers, so kind of places where they can talk about the issues that are coming up for them in the work.
Most of the training I've done is actually from the women I've worked with. It's from listening to the people that we're working with and what's helping them and what's not helping them. I've seen an enormous amount of courage in the women who come to us and what they've already got through and in what they're willing to tackle to get through this stage, when by the time they come to us they're working on trying to heal, trying to recover, trying to get better. And the courage that women show in facing things, in dealing with their problems, in looking at what's gone on for them is awe-inspiring, really.
They've got to be sympathetic, because the worst thing you can possibly do, when you've cut yourself, you feel 100 times more vulnerable than anybody else. The slightest rejection or criticism is going to make you feel 10 times worse. It's not going to do any good at all.
In our organisation we've got 3 core values, which are honesty, empowerment and respect, and I think if everyone was able to provide those, the rest all falls into place. People who self-injure need to be treated with respect. They're human beings, they're not bad people, they're not mad people. They need empowerment, they need to be able to take their own decisions in life, and they need people to work alongside them if they want to stop injuring, and they need to be treated honestly.
I've got a partner and 2 daughters. I've recently left university and I'm doing quite a lot of voluntary work. I want people to make informed opinions about me, not snap opinions because of their misconceptions about self-injury. I don't want people to treat me with kid gloves either. I just want to be accepted as anybody else and treated accordingly.